Okay, so now let's talk about a very important disease called as celiac disease. Okay, and this is a disease that is so spoken about right now these days, talking about gluten-free diet and gluten in gluten sensitive patients and stuff like that. So let's talk about a case first. Let's talk about a case first. There was a 28-year-old female. She came to the OPD and she's complaining of, you know, she's having anemia. She's having osteoporosis. She's also having some form of Fe deficiency anemia. She also complains of a little bit of bone pain, as I told you, because of osteopenia. And we check her ALT, AST enzymes, so they are high. Okay, AST, ALT are high. So you go around and thinking about liver disorders, thinking about anemia being associated with probably some bilirubin or something which is causing some jaundice, probably, which is causing AST, ALT high. You think about all of that, and you check the liver's fine, just the ALT is elevated, not much. So then you wonder about what other disease the patient can have, right? And also she has certain amount of amenorrhea, infertility. So you think about any pituitary cause, and then you check for the pituitary, and the pituitary also is perfectly fine. So what is the problem? And then when you do a peripheral blood smear, you see hyposplenism, associated Howell jelly bodies in the RBC, and you're just lost. Okay, there is an Fe deficiency anemia. There's also at the same time a Howell jelly body seen. So what could be wrong with this patient? Well, turns out the patient had the celiac disease, and that is exactly what an atypical celiac disease is called. So celiac disease is affecting a large part of our population, but only some part of it is diagnosed as a typical celiac, because those are the part of the population that we know of with the typical celiac disease disorder. So beginning with celiac disease, let's talk about the most important uh, pathology of it. But before that, if someone says that they have tropical sprue, they have gluten sensitive enteropathy, or celiac sprue, it all means the same. It's all the celiac disease. So let's talk about the classical celiac. Okay, what I gave you as a case was an atypical celiac, just to prove the point that celiac disease has a wide array of manifestations. Okay, so it could manifest as this, it could manifest as anemia, it could manifest as God knows what, it could manifest as a lot of things, and it's usually seen even as an IBS like syndrome. Okay, but the classical celiac, what does that look like? Well, the classical celiac is a, a simple case of malabsorption. All right, the patient will come, he/she will have osmotic diarrhea, and there'll be loss of glucose, there'll be loss of probably even fats from the intestine, and even vitamin loss. So they could be steatorrhea as well. Okay, so there is a complete malabsorption, there's loss of protein as well. A very important point is that there is no particular age group that's affected in celiac disease, no age, and there is no particular gender, no gender. So usually we have a predilection about how which group or which gender is affected by a particular disease. So we say Hashimoto's is in females, Hashimoto thyroiditis is female to male, 8 is to 1 ratio, 14 is to 1 ratio, sorry. And similarly, we've got ratios, but here there's nothing like that, so it could affect literally anyone. Well, the pathology, let's talk about the pathology. Well, as I told you, it's because of gluten, and this gluten has something called as gliadin inside it. All right, so it has gliadin, and this gliadin is a very important antigen. Okay, so this gliadin enters the uh, enterocyte. Okay, it enters the enterocyte through very very important enzyme. Okay, it's called tissue transglutaminase. Now it enters from the enterocyte into the lamina propria with the help of this tissue transglutaminase, and this tissue transglutaminase is getting the gliadin inside. Okay, and it has been deaminated by deaminase. Okay, so tissue transglutaminase has one function of getting it in. Sadly, in the diagram, the second very important enzyme is not mentioned, which is called as the deaminase, which deaminases the gliadin and makes it a deaminated gliadin. Now this deaminated gliadin is picked up by the antigen presenting cell, Well, this antigen presenting cell picks it up, it presents it to the CD4 T cells. Okay, you know the basic mechanism. And the CD4 T cells are stimulated. They are stimulated, and once they are stimulated, they stimulate the B cells with the help of some interleukins. Usually, interleukin. I think you should be able to answer it as well. Interleukin 5 and all. So definitely, it goes and it stimulates the B cell, and the B cell starts forming IgA dimers. Now, these IgA dimers are very important because they also form a diagnostic value. They have a lot of diagnostic value, correct? So these IgA dimers are released into the circulation and also into the lumen, all right, because they are secretory antibodies. So again, these, when they are released into the lumen, they bind with the gliadin and again promote its uptake. Okay, so that's what I'm saying, it binds again to the gliadin and promotes its uptake. So there's nothing very different. Because of these IgA antibodies that are formed, there's going to be a lot of lymphocytic infiltrate, and the lymphocytic infiltrate is also another hallmark feature. When you see in the biopsy, there's going to be a lot of lymphocytic infiltrate. As I told you, the patient is going to come to you because of all of this with osmotic diarrhea, abdominal distension, weight loss, foul stool, and IBS like symptoms. The atypical symptoms were the one that I already spoke of, correct? So what should you do? Okay, so what should you do? Would you stop gliadin? Yes, if you stop gliadin, and usually the symptoms are reversible. Okay, fair enough. So how do you want to diagnose it? What do you do for diagnosis? Obviously, you do serology. You check for antibodies. Which antibodies? You check for anti-tissue trans glutaminase, okay, which we call as TTG. Okay, and you also check for anti-deaminase. Simple. And you also check for anti-endomysial antibody. Now this has the most specificity, but usually you check these two. This is done by IFAT, indirect fluorescent antibody detection, or indirect immunofluorescent detection. These are the three antibodies that you should remember. Now, if the serology is positive, okay, and the biopsy is negative, okay, let's say you do a serology and then you check for a biopsy and the biopsy is negative, you want to repeat the biopsy, okay. So what has more importance, serology or a biopsy? Definitely a serology has more importance, because if the serology is negative and the biopsy is yet positive, you say that no, it's not celiac for sure. So what do you see in a biopsy? Just because a biopsy is also important, what do you see in a biopsy? Well, you see villus atrophy, as you can see here in this particular diagram on the left. There is villus atrophy. So look at the villi. The normal villi is taller, and the villus atrophy causes it to shrink, but the crypts are enlarged, because the crypts are the dip between the two villi. So the crypts are enlarged. They are hyperplasia of the crypt is seen, and the total mucosal thickness definitely remains the same. If you look at it, what actually occurs is that there is a lot of infiltration of lymphocytes in the lamina propria. So these white ones are the lymphocytes, L. So there's going to be lymphocytic infiltrate, and that's pretty obvious because there is a T cell that is present, there is the B cell that is present, and that's pretty obvious. And also there is a certain amount of, say, as I've told you, intraepithelial lymphocytes are seen. Out here is also mentioned. Okay. What is it associated with? Well, it's associated with HLA DQ2, and DQ8. Okay. The D-xylulose test is negative. Obviously, D-xylulose test is negative because of malabsorption. Nothing is being absorbed. D-xylulose is directly absorbed in the blood, and then you check the urine level of D-xylulose. It has to be above a particular threshold value to say that, okay, the absorption is perfect, but here it isn't. Simple case. After that, what sites are affected? Okay, what sites are affected? Well, the distal duodenum is affected, and also the entire jejunum is affected. All right. Once that is cleared, let's talk about the atypical celiac that I already spoke of. Fe deficiency anemia. He'll have IBS like syndrome, osteopenia, amenorrhea, also the patient can present with AST, ALT elevation. Okay, ataxia, hyposplenism, etc. What is a refractory celiac? A refractory celiac is that, let's say you stopped gluten for 6 months, but yet the symptoms do not better. Okay, they worsen rather, they do not improve, they just worsen. So then it's refractory celiac. Now, some other disorders that are actually seen with celiac, and it's seen with classical celiac too. Okay, it's not something that's only a part of atypical celiac. It's simple. You see, you see a very important disorder called dermatitis herpetiformis. We also see IgA antibody associated nephropathy. All right. We also see DM1, diabetes mellitus type 1. There's also hypersensitivity pneumonitis. That's very important. Okay. And you can see Down syndrome. But Down syndrome is again it's more of a genetic. It's trisomy 21. So it's not that is seen due to celiac, it's seen with celiac, or celiac is seen with Down syndrome would be a better way of putting it. How do you want to treat it? Simple. Stop gluten. Okay. But if it's refractory, I told you, if it's refractory and with stopping of gluten, yet there is no improvement in symptoms, then you have to go for steroids. And if it's a refractory celiac, you are at a very high chance of having an adenocarcinoma, okay, an esophageal squamous cell carcinoma, or an EATL. That's an enteropathy associated T cell lymphoma. Not seen much very commonly, but obviously you need to remember adenocarcinoma of the small intestine and obviously your esophageal squamous cell carcinoma. Very important. So I think that is about it for celiac disease, a very important topic, not as commonly shown by the media, but very different from what we think of it or we perceive of it. So that is about it. Thank you very much.